topic of my today's presentation is the high levels of serum ferritin levels and poor COVID-19 outcome. The nutritional prospects which has been lost, one should consider the nutritional aspects while dealing with the COVID-19 infection. Myself, Dr. Pranita Jwalant Wagmare. I am professor at Department of Biochemistry, MJMS Sevagram. So the COVID-19 infection has a great impact on us, and what we should learn or we should have a take-home message from that particular episode of pandemic that while dealing with the COVID-like infection in the futures. So just to have the link between serum ferritin levels and COVID-19, the COVID-19 has challenged the health sector in many ways, starting from its diagnosis, the different strategies for its prevention, the treatment and complete cure from the COVID-19. The scientists are still struggling for the drug discovery, the vaccination for the COVID-19 or COVID-19 like diseases in the upcoming futures, the immunomodulatory strategies, and of course the lifestyle changes, having the lower decrease in the obesity, the prevalences of the hypertension and diabetes mellitus. As we all know, this diabetes mellitus, obesity, hypertension are the risk factors for COVID-19 infection and the mortality resulting from the COVID-19 infections. And what is common in all these three or all the diseases which are said to be the risk factors for the COVID-19 infection is the inflammatory status of an individual. So those individuals are actually having the more inflammation, they are more prone to have the COVID-like mortalities. Okay, and that's why the inflammatory markers like C-reactive proteins and D-dimers have come in a way which have the predictive values in predicting the disease outcome. And what is a hallmark for this COVID-19 like diseases and mortality is the cytokine storm. And what is that the cytokine storm is that it is the exaggerated inflammation leading to the acute severe infection or acute severe COVID diseases leading to the multi-organ failure and leading to the death of that particular individual who is suffering from the COVID-19 infection. And in that reference, the high ferritin levels are supposed to exaggerate the inflammatory levels, with putting the more oxidative stress on an individual, and consequently the more COVID-19 complications. And why this ferritin is supposed to, or how it is going to add on that inflammation, cytokine storm, or the mortality for the COVID-like diseases is the way that this elevated levels of ferritin, they leads to the more fibrin polymerization and inducing the more procoagulant state. It is producing more ROS, that is reactive oxygen species, and putting the individual on the stress. It activates the phosphatidylinosydyl pathways and enhances the NF-kappa B, encouraging the expression of more inflammatory cytokines. And the H chain of ferritin also facilitate the release of inflammatory cytokines. And all this together are putting this cytokine storm. All they are together putting the individual at the more inflamed condition. That is what we call this as a cytokine storm. So what are the factors which are responsible for maintaining the serum ferritin levels? The many factors including the genetic factors, biological factors, age of an individual, sex of an individual can determine the serum ferritin levels in that particular individual. Besides that, the population where it resides, that particular, if we are talking for the rural populations are having the low levels of iron supplementation. Probably they are having the low iron levels. Consequently, their serum levels of ferritin will be very low. Besides that, economic status of an individual, the approach of that individual for having the dietary habits, and the education of that particular individual also matters or affects the serum ferritin levels. It has been also seen that the proper supplementation of vitamin B9 and vitamin B12, which are required for the absorption of iron, also have the effect on the serum levels of ferritin levels. Then the BMI, the obesity, they also have the levels, the effects on the ferritin levels. The albumin levels also affects the serum ferritin levels. and ultimately the blood group typing, the patient or the subject having the blood group also affect the serum ferritin levels, and that's why we have underwent a study to see the association between the serum ferritin levels and different ABO blood group in the COVID-19 patients, and it was a retrospective study. And what was the objectives for this study? Is to study the differential prevalence of COVID-19 and its relation to the ABO blood group in the patients being admitted in our tertiary care hospital. And the second primary objective was to study the association between blood group and serum ferritin levels, if any, in the adverse outcome of a COVID-19 infection. That particular study has been published in 2023, and what we observed in our study is that here in the red marks are the deaths resulting from the COVID-19 in the different blood groups, and this green one are the prevalence of COVID-19 in the different blood groups. Here we can see that the blood group O and B are having the highest prevalence of COVID-19 infection. But when we see the mortality in the COVID-19 infection in the different blood groups, what we observed was the blood group AB is having the highest mortality of the 27%, followed by the blood group A with the 22% of the mortality. So when we see the ferritin levels of the individuals with blood group AB and blood group A, all blood typing, we go for the serum ferritin levels, and what we observed is that the blood group AB is having the highest levels of ferritin levels, that is almost 1007 nanograms per ml, followed by, which is having the highest mortality rate amongst all four blood groups, followed by the blood group A, which was the lower compared to the AB, but still it was highest. About 22% of the populations from the blood group A resulted in a bad outcome in the form of death, and the serum levels of ferritin in that particular patients was the mean levels were in between. The mean value was 527 nanogram per deciliters. And when you try to correlate these findings of high levels of serum ferritin levels with the enzymatic markers of hepatocytes, that is liver, that is aniline transaminases and aspartate transaminases, what we observed that the subjects with AB blood group are having the highest levels of aniline transaminases as well as the aspartate transaminases. So what we conclude from our study is that the subjects with AB blood group are having the highest death rates with highest layers of serum ferritin levels. This raised serum ferritin levels may be considered as one of the trigger for the inflammatory response, and which has been further validated by the raised levels of alanine transaminases and aspartate transaminases in the subjects with AB blood group. But here what we like to propose is that as we have already discussed that the subjects from the rural populations are having the low levels of ions due to the many factors, the availability, the economic status of that particular individual, they are not able to get that particular amount of iron. So uh, just seeing at the iron levels, it is not recommended for the clinician to see the significant difference in the pre and post levels of ferritin levels. The marginal levels or the marginal rise in the ferritin levels are significantly depicting the changes in the inflammatory markers of that particular individual. Uh, Besides that, the serum ferritin levels are also dependent on the many factors, as the patient is having the iron deficiency anemia or the patient is vitamin C deficient, so iron absorption will not be there. Obviously, low ions will be there, reflecting the low levels of ferritin levels. Copper deficiency, as we know, copper is also required for the absorption of iron. Ultimately, it will lead to the low levels of iron and low levels of ferritin levels. Low levels of folic acid and vitamin B12 also responsible for the low levels of iron and consequently the low levels of ferritin levels and celiac diseases. And that's why what we propose here that the clinician should also consider the other factors while considering the ferritin as inflammatory markers, and the clinician also see for the other causes for low levels of serum ferritin levels in that particular individual. And as we concluded here, the nutrition has a role in defining the status of the recurring status of an individual who is suffering for the COVID-19. Here we propose the nutritional aspect are the most important one to be considered, which are the neglected ones to define the person or the subject is more prone to get or to more acquired to get infections like COVID viruses. So it is very important to know the nutritional status of that particular individual or the food security that individual is having. So when we talk about this, the particular pathway of COVID-19 disease, the first one is the susceptible host. As we know, the individuals we are having the diabetes mellitus, who are having the hypertension, who are obese, already having the sickle cell diseases, respiratory diseases, are more prone to easily get entered the virus inside them. Once the once virus get inside their body, there are certain factors which can define the replication strategies or multiplication rate of that virus, and that multiplication rate will be dependent upon the nutritional status of that individual, like the antioxidant status, the antioxidant enzymes like superoxide dismutase, catalase, glutathione peroxidase, the protein content or protein security that particular individual is having, the trace elements, the important trace elements, the zinc, magnesium, copper, calcium, iron, the vitamin levels, the vitamin D, C, folic acid, vitamin B12 are the determinant to prevent the viral load and getting the disease conditions. This is one part. Another part, the 2 and 3, which I have highlighted in this red color, are these area which are very gray areas and no such solid information is available, which can say that yes, this nutrition has a role in preventing the COVID-19 diseases, or supplementation of this deficient nutrient during the phase of infection can lead to the better outcome of individual and reduces the mortality resulting from the COVID-19 infection. Obviously, the other conditions which have the increased rates of inflammation in that particular individual, like the smoking, the cancer, the liver diseases, the autoimmune diseases, the tuberculosis, and use of the immunosuppressant can also decide the fate of individual who is suffering from the COVID-19 infection. So coming to the first trace element, the most important one is the zinc. As we know, the zinc is important to maintain the integrity of the tissue, and it is very important. It prevents the entry of virus inside our body. So zinc has been shown to have the antiviral effect against the various type of viruses, including the coronavirus. One more thing is that zinc inhibits the RNA polymerase activity, and thus it prevents the viral lysis or prevents the viral load inside the body. So it has a role in preventing the entry of virus inside body. Even though the virus get entered, it has a role in stopping down the multiplication of this coronavirus and decreasing the viral load. And it has been reported that the subjects with chronic deficiency of zinc are associated with the increase in the pro-inflammatory cytokines. So one study has been carried out by the Benin et al. They have seen what they reported that the zinc supplementation during the disease period has been considered as a potential therapy for coronavirus disease. The oral zinc can decrease the death rate in ICU admitted patient, and also it can shorten the duration in ICU and the duration of disease. So here is the question. So it is mandatory or low serum levels of zinc can trigger the risk of COVID-19 like infections, the cytokine storm, and related mortality in the subjects who are suffering for who were suffered from the COVID-19 infection. And in future, one should be very much cautious about their serum levels of zinc. They should have the zinc supplementation daily. The another most important element is the calcium. The hypocalcemia has been observed in almost 60% of the subjects who are hospitalized with the SARS infection. And this calcium or hypokalemia is involved in the regulation of inflammatory responses. This hypokalemia is as a result of hypovitaminosis D. That is, whenever we have the low levels of vitamin D, calcium cannot be absorbed. And again, the hypoalbumin, as the carrier, we require the albumin to carry the calcium. So all these are linked. So low levels of vitamins, the low levels of albumin can lead to the low levels of calcium. So hypokalemia or low levels of calcium, besides the decrease in the supplementation of calcium levels, the another causes one should have in their mind is that the low levels of vitamins can also affect the or also reflects low levels of calcium, and low levels of albumin also reflected as a low levels of calcium. Low levels of albumin also reflects the low levels of calcium. And one of the study has shown that the hypokalemia, along with the C-reactive protein and the inflammatory marker of interleukin 6, are independent risk factors for the COVID-19 poor outcome. So it is very important to maintain our calcium levels between the 9 to 11 milligram per deciliters. One more thing is that the levels of calcium trigger the cytokine storm and related mortality, and that's why it is very important to maintain the serum levels of calcium. And to maintain the serum levels of calcium, what is important? To have the vitamin D the supplementations of vitamin D. Again, one more thing we can go here is that for vitamin D to be get stored, one requires the fat. So the as it is a fat soluble vitamin, so it is a holistic approach. The proper amount of fat, the proper amount of vitamin, the proper amount of protein, the proper amount of sugar, the proper amount of trace element are able to fight against the COVID-19 infections. Then the iron, whenever we have the COVID infection, the iron levels, the intracellular iron get increase, and this intercellular iron is responsible for the innate immunity. And how there is increase in the intercellular iron level, it is by increasing the hepcidin levels and inhibition by the ferroportin levels. So whenever there occurs a lysis of that particular cell, the iron will be released into the blood, and that will result in the high levels of iron, high levels of ferritin levels, and which will trigger the inflammatory cytokine storm, leading to the acute inflammatory condition and the death. One more study by the Hippenson and et al. They showed that the iron concentration less than 6 micromole per deciliter are the optimal cutoff, which decides or predicts the hospitalization of the patient with the COVID-like infections. The copper, as we know, the copper is the most important constituent for the enzyme of superoxide dismutase, and this superoxide dismutase which deals with the oxidant, the superoxide, and prevents the oxidative stress. So the proper supplementation of copper is important to have the levels of superoxide dismutase in our body. One more thing, that is copper is also required for the transferrin activity and ferroxidase activity, and that's why the patients, when they are deficient with the copper, they are at risk of iron deficiency anemia. And once the patient is having the iron deficiency anemia, the more hypoxia like related conditions will be in the subjects who are suffering from the COVID-19 infection. So it is also important to maintain or to have the proper supplementation in our body. The vitamin B12, the cobalamin has a role in immunity of an individual. The vitamin B12 affects the T and B lymphocyte differentiation between the cytotoxic T cells and T helper cells. The vitamin B12 also involved in the cell division, which can directly impact the rapid proliferation and result in the reduced need of supplementation of oxygen in the ICU admitted patients. The study involving the almost 50-year-old individuals which were suffering from the COVID-19. It has been reported that the supplementation of vitamin B12, vitamin B3, and magnesium are related with the lesser complications in the SARS or COVID-like infections. So here is one more concern for the vitamin B12 is that the strict vegetarians they may be at risk of getting the COVID like infections, and even though they are more prone or getting acquired for the COVID like infections, there are more chances of getting the cytokine storm. Then one more is the vitamin C. Vitamin C regulates the production of cytokines, controls the release of histamine, reduces the oxidative stress, and induces the differentiation and proliferation of B and T lymphocytes. Vitamin C is widely recognized as an antioxidant, and one of the study conducted in the United States involving the 167 patients, what they reported is that the ARDS, that is the acute respiratory distress syndrome, the administration of approximately 1 gram of a vitamin C per day has decreased the patient mortality. So how much here the gray area what we are talking about is that does nutrient supplementation during the phase of disease. Once we acquire an infection, can we modulate the fate of that particular infection? Yes, we can modulate the fate of infection by giving the vitamin C. The vitamin D, multiple studies have demonstrated that the low levels of vitamin D status are associated with the increased risk of severe COVID-19 infections. The significance of vitamin D, it has a role both in adaptive as well as innate immunity. And one study which has been conducted in the patients, it has been seen that those patients who have the low levels of vitamin D, they have the higher levels of inflammatory markers when we compare that with the asymptomatic patients. So thus this vitamin D supplementation, as we already said, the vitamin D is responsible for the low levels of calcium. Both hypokalemia and vitamin D are responsible for the increased inflammation in an individual. So to conclude, what we can say is that the nutrition plays a crucial role in supporting the immune system by aiding to acquire infection like zinc. Zinc can prevent the entry of the virus inside the body or prevents the replication of virus inside the body. To fight against the infection, they can reduce the duration of infection. The proper nutrition can reduce the duration of infection, and it can also decide the recovery, the fate of infection. So hence it is very crucial to understand the nexus of nutritional status of an individual in a milieu with COVID-19 infection, outcome, and as the pandemic has been over, one has to be very prepared for the next upcoming COVID-like infections in the future. So what makes an individual a susceptible host? The individual who is deficient in the vitamins like vitamin C, vitamin D, minerals, the deficient minerals which are responsible for making the susceptible host for acquiring the infections are zinc, manganese, magnesium, copper, calcium, iron, and selenium. Then adequate calories and protein are necessary to maintain the immune cell production and functioning of them during the infections, and proper or exact the high levels of antioxidants to get fight with the oxidants which are produced during any infection. And the gray area which very low or very small information is available, the supplementations during the infection can change the fate of that disease and decreases the mortality related with the COVID-19 infections. That's all from my side. Thank you so much. If anyone
Joining this webinar conducted by the 4th International Conference of the Midwifery and the Women Healthcare at Dubai. I am Dr. Shakil Ahmed, currently serving as the Senior Resident in the Department of Pediatrics, Pushpagiri Medical College, India, Kerala, India. So, first of all, at the outmost, I would like to thank the organizing committee of this conference for giving me the opportunity to be part of this prestigious event as a speaker. So today, I'll be sharing some insights into a research which I had conducted when I was the junior resident at Sri Gokulam Medical College and Research Foundation at Trivandrum, Kerala, under the guidance and mentorship of Dr. Lelda Kailas Madam. So So this was my study that was to assess the relationship between the serum zinc levels and the febrile seizures, and this was a hospital-based case-controlled study. So, moving on to the introduction, we all have encountered febrile seizures in our casualty. So, what I wanted to tell is that it is a significant type of seizures, and it is the most common type of seizures in children aged between 6 months to 6 years, usually from 6 months to 6 years. So, it is a seizures which occurs along with a febrile illness in a neurologically normal child without often any long-term developmental sequelae. But as we all know that it is often distressing to the parents. Hence, we need to address them. We need to counsel them regarding the prevention and recurrence of this febrile illness. So various hypotheses have been formulated regarding the causation of febrile seizures, and the most of them are pointing towards the immature or immature response of the developing brain to the heightened temperature. So we know that there have been various etiologies which can provoke febrile seizure, like a significant family history or any history of deficiency of iron, etc. So there have been many studies which shows that the deficiency of zinc might lead on to the occurrence of febrile seizures. So, as we all know that the zinc, it is a trace element, which is a critical micronutrient, which is involved in the growth, the immune response, the enzymatic activity, the protein synthesis, as well as the enhancing the neurological functions, as well as the immune functions in our body. So what the zinc does is, in the context of seizures, it is present in the synaptic vesicles of the glutaminergic neurons. So what it does is, basically the seizures happen when there is an imbalance between the excitatory as well as the inhibitory neurotransmitters. So what it does is, it helps in reducing this imbalance. So to further elaborate on that, what it does is, it helps in influencing the action of glutamic acid decarboxylase, which helps in the further enhancement of inhibitory neurotransmitters like your gamma aminobutyric acid. And it also has an opposing effect on the excitatory neurotransmitter, that is your glutamate, as well as on the NMDA receptors. So the zinc, it is when there is an electrical stimulation of the neurons, this zinc, it is released from the synaptic vesicles, and it goes on to do the actions which I had mentioned before. So talking after the pathophysiology, our aim of the study was to compare the serum zinc levels in children experiencing the simple febrile seizures versus those with acute febrile illness without seizures, and to look for any potential correlation between serum zinc levels and the occurrence of febrile seizures. So what was the primary objective of my study? It was basically to compare the serum zinc levels between children with febrile illness and those with acute febrile illness without seizures. And what was the secondary objective? It was to find out the prevalence of hypozinzemia, that is serum zinc levels less than 65 microgram per deciliter, according to WHO, in our case as well as in our control group. And also, we aim to identify any significant relationship between serum zinc levels and variables such as the type of febrile seizures, the recurrence rate, the etiology, the age, and the gender. So moving on to the materials and methods, my study, it was basically a hospital-based case controlled study done at Pushpagiri at Sri Gokulam Medical College at Trivandrum, Kerala. And basically the data which we collected were from children who had visited our pediatric inpatient department and the casualty. So who all were included, all the babies and children aged between 6 months and 72 months coming to the pediatric casualty and the pediatric IP department. And we have done the study for a period of around 19 months from December 2022 to June 2024. So moving on to the inclusion criteria, the children which we handpicked were the children aged between 6 to 72 months experiencing simple, complex or status febrile seizures, that is seizures occurring in a developmentally normal child during a febrile illness without any CNS infection like your encephalitis or meningitis or any other specific causes of seizures. Moving on to the exclusion criteria, who all were excluded? So the children with a past history of established afebrile seizures, children with neurological infections, any inborn errors of metabolism, any children with persistent neurological deficits like your cerebral palsy, or any history of any recent zinc intake in the past 3 months, like for example, in pneumonia, diarrhea, etc., and children aged less than 6 months and older than 72 months. So this was the formula which we had decoded, and with the help of that formula and with a 95% of confidence interval, 80% power, and the probability of the even case group as 52% and 30% in the control group, we estimated a sample size from the case group with 79 and from the control group was 79. So the sampling method which we had used was a consecutive sampling involving the case and the control group. And for the control group specifically, we had instituted a random sampling with similar age to samples in the study group. So after taking a detailed history, like example, taking the family histories, any the recurrence, etc., and the duration of the fever, we had collected the zinc value, the serum, using a 22 gauge needle, and we had sent it to a laboratory for processing. And the process of zinc was using measuring zinc. We used colorimetry, which relied on the fundamental principles of photometry. And the zinc values were hence estimated with the help of our biochemistry department. So moving on to the observation and the results. So the first result was there was a distribution of the sample according to their age in months. So as you can see from the table, it is seen that the most of the patients in the case group belongs to the 6-month to 12-month age category with 41.8%, whereas in the control group, most of the patients belong to the 25 to 72 months, that is 53.2%. And distributing the sample according to the gender, most of the patients in our case group were females and the rest were males. Whereas in the control group, most of them were males and the rest were females. So once we decoded the family history from the case group, it was found that around 43% had a negative family history and around 57% had a positive family history of febrile seizures. So next, after receiving the serum zinc values from our biochemistry department, the average serum zinc values in the case was 81.1 microgram per deciliter with a standard deviation of 42.1. Here it is depicted in an error bar with the standard deviation. And the average serum zinc values in the control group were 142.4 with a standard deviation of 69.8. So what we did was, after analyzing this serum zinc samples in both case as well as control, we did an independent sample t-test which compared the mean serum zinc values between the cases and the control. So this was the main crux of our study. And we found out that the results of the independent sample t-test in this table, which indicated that the mean serum zinc level was 61.3 microgram per deciliter less in cases as compared to the controls. And this difference was statistically significant at a 1% level of significance. So next we moved on to the average serum zinc values for the cases by gender. And from this table and this pie bar chart, you can find that the average zinc values in males were 80.3 compared to 81.9 in females. And the similar goes for the gender, that is in the control group, the average zinc values in males were 156.3 compared to 126.7 in the females, with a standard deviation of 69.8. Also, we conducted an average serum zinc values for cases by age, and it was lowest in the 13 to 24 months among the case group. And in the control group, it was lowest among the 25 to 72 months category. So we also basically what I'm right now telling is about the second objective, to find any correlation of zinc deficiency with uh, variables like your age, gender, recurrence rate, type of febrile seizures, and the etiology. So moving on to the etiology, you can see that we had total 79 cases and 79 controls with the various etiology. And we also assess the mean zinc values based on the diagnosis. And the mean serum zinc values in the was lower for children with bronchiolitis among the cases, while among the controls, the mean serum zinc values were observed in children with acute lower respiratory tract infection. I hope you are following me. Can everyone hear me?
Yes.
Okay, fine. Next, moving on to the mean zinc values by the type of febrile seizures. So these are the types of febrile seizures which we had received in our casualty as well as in our inpatient department. We can see that there is not much difference in the mean zinc values between the complex febrile seizures as well as the simple febrile seizures. So we again did an independent sample T test that compares the mean serum zinc values by the type of febrile seizures. So we got a p-value of 0.926, which states that there was no statistically significant difference in the mean zinc values between the children with simple febrile seizures and complex febrile seizures. Hence, the type of febrile seizures could not be influenced by the low levels of serum zinc in our study. So this we meant to estimate the zinc values by the episode. If the child presented with first episode or recurrent second episode, etc. So we had done a chi-square test to know if there was an association with hypoxemia, which I told before, that is serum zinc less than 65 microgram per deciliter according to WHO with respect to the recurrence of febrile seizures. But we got a p-value of 0.354, which shows that such an association is statistically insignificant in the study. So next, the final thing what we had done was to compare hypoxemia, that is zinc values less than 65 microgram per deciliter in our case as well as in our control group based on the estimate samples we got. So we found out that in our case group, we had around 48% with hypoxemia, and in our control group, we had around just 6% with hypoxemia. So what in this slide, what I would like to show you guys is these were the various studies which I could recollect from around the world, which compared the serum zinc values with febrile seizures as well as in children with febrile illness without seizures. And you can see the various values they had got. And in our study, we got in the serum zinc values in cases 81.1, in control 142.4, with a mean difference of 61.3, with a p-value of 0.01, which is statistically significant. So mainly why this table was put up was that the most of the studies, they had a limited sample size, around 40, 45, etc. But our study, we had a significant sample size that was 79 in case and 79 in controls, and we got a statistically significant result. So finally, I would like to conclude that in our study, we observed a statistically significantly lower serum zinc levels in children who experienced febrile seizures compared to febrile children without seizures. Also, we found out that hypoxemia, that is serum zinc levels less than 65 microgram per deciliter, was present in around 48% in our case group compared to 6% in our control group. Also, in our study, we could not find a statistically notable link between the low serum zinc levels with respect to the age, gender, etiology, recurrence, and the type of febrile seizures. So, finally, as a writing on the wall, I would like to say that with our study, we found out that children with febrile seizures children with zinc deficiency had a heightened risk of febrile seizures. So I hope that we need to find out and we need to address as well as monitor this serum zinc status in the pediatric age group, especially pertaining to the management of febrile seizures. And I hope that this study will serve as a foundation to make more guidelines regarding the supplementation of zinc in preventing the further recurrence of febrile seizures in a children. So thank you all for your patient listening, and I'm happy to take your questions. Thank you.
The title of this presentation is Reversal of Fetal Growth Deceleration with Maternal Left Lateral Rest. Findings from 4 retrospective cohorts. This presentation is based on 4 peer-reviewed studies from my center. The first paper I will discuss was published in the American Journal of Obstetrics and Gynecology in January 2025, followed by 3 studies published in the Journal of Clinical Ultrasound. In 1988, a nurse asked, "Where are all the dead babies?" I asked, "What do you mean?" She told me that since I had introduced a fetal diagnostic program at the hospital, the stillbirth rate seems to have decreased. I did a study for 2 15-month periods before I started the program in 1987 and noted the stillbirth rate was 6.02 and 6.09 per thousand births. 15 months after I started the program, it fell to 2.31 births per 1,000. Looking back, I reviewed the stillbirth rate in Utah as listed on the right of the screen for the entire state of Utah. My program demonstrated a drop in stillbirth rate from 7 per 1,000 to 5.3 per thousand and then rose again after I left the state. One of the major treatments that I introduced was placing mothers at rest in the left lateral position when I discovered poor fetal growth. This was the genesis for the studies I published last year after reviewing over 20 years of evaluating fetuses for abnormal growth and other adverse outcomes from my California practice, which began in 2000. Fetal growth restriction and small for gestational age status, commonly defined as an estimated fetal weight below the 10th percentile, are linked to increased perinatal morbidity. Recent observational studies have explored whether prescribed maternal rest in the left lateral recumbent position reverses decelerated growth trajectories identified by various criteria, including absolute deceleration thresholds, percentile drops, and abdominal circumference velocity metrics. This study, published in the American Journal of Obstetrics and Gynecology in January 2025, entitled Maternal Rest Improves Growth in Small for Gestational Age Fetuses Less than the 10th Percentile. Let's review the findings. The cohort of 265 fetuses was compared to contemporaneous controls at sea level, the Texas, Michigan group, and a population at 5,000 feet above sea level, the Colorado group, both of whom did not advise maternal rest after the diagnosis of a SGA fetus was made. The graph in the upper left panel A with the blue dots demonstrates the estimated fetal weight before the diagnosis of a fetal weight less than the 10th percentile, as illustrated by the red dots in panel B. To qualify, all fetuses had to have a normal EFW prior to the diagnosis of an EFW less than the 10th percentile. Panel C demonstrates that 75% of fetuses improved their weight above the 10th percentile after maternal rest of 2 weeks. Panel D demonstrates the individual changes prior to and after bed rest. The bar graphs on the right identify the mean percentiles for the 3 time periods: AGA or appropriate for gestational age, SGA or an estimated fetal weight less than the 10th percentile, and bed rest. The increase in the percent of fetuses with an EFW 10th percentile following maternal rest was statistically significant. The same trend occurred for the abdominal circumference. Prior to the diagnosis of an EFW less than the 10th percentile, 92% had an abdominal circumference above the 10th percentile. Following the diagnosis of an EFW less than the 10th percentile, only 17% had an AC greater than the 10th percentile. Following maternal rest, the AC was above the 10th percentile in 67% of fetuses. The AC mean percentiles of the 3 time periods are listed in the graph on the right side of the slide. The increase in the percent of fetuses with an AC greater than the 10th percentile following maternal rest was statistically significant. The same trend occurred for the head circumference. Prior to the diagnosis of an EFW less than the 10th percentile, 96% had a head circumference above the 10th percentile. Following the diagnosis of an EFW less than the 10th percentile, 78% had a HC greater than the 10th percentile. Following maternal rest, the HC was above the 10th percentile in 86% of fetuses. The HC mean percentiles are listed in the graph on the right side of the slide. The increase in the percent of fetuses with an HC greater than the 10th percentile following maternal rest was statistically significant. The same trend occurred for the femur length. Prior to the diagnosis of an EFW less than the 10th percentile, 95% had a femur length above the 10th percentile. Following the diagnosis of an EFW less than the 10th percentile, 49% had a femur length greater than the 10th percentile. Following maternal rest, the femur length was above the 10th percentile in 71% of fetuses. The femur length mean percentiles are listed in the graph on the right side of the slide. The increase in the percent of fetuses with a femur length greater than the 10th percentile following maternal rest was statistically significant. When the results were compared with the 2 control groups, both of which did not instruct their patients to begin maternal rest after the diagnosis of an estimated fetal weight less than the 10th percentile was made. For the Denver group, who lived at 5,000 feet above sea level, only 12% spontaneously improved their weight greater than the 10th percentile. For the Texas-Michigan group, who were at sea level, only 19% improved their weight after 2 weeks. These values were significantly lower than the group from our study, in which 75% improved their weight above the 10th percentile after maternal rest was instituted following the diagnosis of an estimated fetal weight less than the 10th percentile. These contemporary controls had values significantly lower than the group from our study in which maternal rest was instituted. In this study, we classified fetuses with an estimated fetal weight less than the 10th percentile as small for gestational age or growth restricted, using the Delphi consensus definitions. Of the 265 fetuses with an estimated fetal weight less than the 10th percentile, 56% were growth restricted and 44% were small for gestational age. The number of fetuses with an estimated fetal weight above the 10th percentile increased from 0% when growth restriction was present, to 70% following 2 weeks of maternal rest. This increase was significant. The number of fetuses with a head circumference above the 10th percentile increased from 73% when growth restriction was present, to 83% following 2 weeks of maternal rest. This increase was significant. The number of fetuses with an abdominal circumference above the 10th percentile increased from 15% when growth restriction was present, to 65% following 2 weeks of maternal rest. This increase was significant. The number of fetuses with a femur length above the 10th percentile increased from 45% when growth restriction was present, to 65% following 2 weeks of maternal rest. This increase was significant. This summarizes the results for the growth-restricted fetuses. For the estimated fetal weight, all had values less than the 10th percentile at the time of diagnosis of growth restriction. Following maternal rest, 70% had an estimated fetal weight greater than the 10th percentile. For the head circumference, 73% had a value greater than the 10th percentile at the time of the diagnosis of growth restriction, which improved to 83% following maternal rest. The abdominal circumference, only 15% had an abdominal circumference greater than the 10th percentile, which increased to 65% following maternal rest. The femur length demonstrated an improvement in the percent of fetuses who had a value greater than the 10th percentile from 45% at the time of diagnosis of growth restriction to 65% following maternal rest. From this analysis, the abdominal circumference demonstrated the greatest improvement following maternal rest. For the SGA fetuses, their estimated fetal weight above the 10th percentile was 0% at the time of diagnosis. Following 2 weeks of maternal rest, the estimated fetal weight above the 10th percentile was present in 82%. This increase was significant. The number of fetuses with a head circumference above the 10th percentile increased from 85% when SGA was present to 89% following 2 weeks of maternal rest. This increase was not significant. The number of fetuses with an abdominal circumference above the 10th percentile increased from 19% when SGA was present to 71% following 2 weeks of maternal rest. This increase was significant. The number of fetuses with a femur length above the 10th percentile increased from 44% when SGA was present to 89% following 2 weeks of maternal rest. This increase was significant. This summarizes the results for the small for gestational age fetuses. For the estimated fetal weight, all had values less than the 10th percentile at the time of diagnosis of a SGA fetus. Following maternal rest, 82% had an estimated fetal weight greater than the 10th percentile. For the head circumference, 85% had a value greater than the 10th percentile at the time of the diagnosis of SGA, which improved to 89% following maternal rest. The SGA fetuses had head sparing. For the abdominal circumference, only 19% had an abdominal circumference greater than the 10th percentile, which increased to 71% following maternal rest. The femur length demonstrated an improvement in the percent of fetuses who had a value greater than the 10th percentile from 44% to 89% following maternal rest. From this analysis, the abdominal circumference demonstrated the greatest improvement following maternal rest, followed by the femur length. These are 3 growth profiles. Graph A illustrates that 56% of FGR fetuses and 72% of SGA fetuses had a return to normal values following maternal rest for the EFW that was sustained until delivery. Graph B demonstrates that 18% of FGR and SGA fetuses grew along the curve but did not increase their EFW above the 10th percentile. Graph C demonstrates that 26% of FGR and 10% of SGA fetus grew but then had an arrest of growth a term. This next section examines fetuses with an estimated fetal weight less than the 10th percentile and 3 different definitions of growth deceleration. In this study, we examined fetuses who had either a growth velocity of less than 20 grams per day, a greater than 30 percentile drop in the estimated fetal weight, or a 50 percentile drop in the estimated fetal weight. The fetuses were from a group of 265 fetuses with an estimated fetal weight less than the 10th percentile. For those fetuses with an estimated fetal weight less than the 10th percentile and a decreased growth rate of less than 20 grams per day, 75% increased their EFW from 0%, measured at the time of diagnosis of an estimated fetal weight less than the 10th percentile, to above the 10th percentile after 2 weeks of maternal rest. This increase was significant. For those fetuses with an estimated fetal weight less than the 10th percentile and a drop in percentile EFW values of more than 30 percentile points, 79% increased their EFW from less than the 10th percentile to above the 10th percentile after 2 weeks of maternal rest. The increase was significant. For those fetuses with an estimated fetal weight less than the 10th percentile and a drop in percentile EFW values of more than 50 percentile points, 64% increased their EFW above the 10th percentile after 2 weeks of maternal rest. The increase was significant. Irrespective of the definition of deceleration of growth in fetuses with an estimated fetal weight of less than the 10th percentile, all responded with improved growth following maternal rest. This study examined fetuses with an estimated fetal weight less than the 10th percentile who had an associated growth velocity of the abdominal circumference less than the 10th percentile. The yellow circles demonstrates values of the abdominal growth velocity above the 10th percentile and the green circles growth velocities below the 10th percentile. At the time of diagnosis, 100% had an abdominal circumference growth velocity less than the 10th percentile. Following maternal rest for 2 weeks, the abdominal circumference growth velocity increased above the 10th percentile in 94% of fetuses. This was a significant increase. At the time of diagnosis of an estimated fetal weight less than the 10th percentile, 61% had a head circumference growth velocity greater than the 10th percentile. Following maternal rest for 2 weeks, the head circumference growth velocity increased above the 10th percentile from 61% to 81% of fetuses. This was a significant increase. At the time of diagnosis of an estimated fetal weight less than the 10th percentile, 46% had a femur length growth velocity greater than the 10th percentile. Following maternal rest for 2 weeks, the femur length growth velocity increased above the 10th percentile from 46% to 83% of fetuses. This was a significant increase. Using MRI technology, Cooper in 2021 reported that there was an increase in blood flow through both the iliac arteries when the pregnant patient was in the left lateral position compared to the supine position. There was also an increase in fetal umbilical vein flow as well as increased blood flow to the fetus. This study demonstrated the benefit of maternal rest in the left lateral position and provides data suggesting the mechanism of improved fetal growth when we placed our patients in the left lateral position once abnormal fetal growth was identified. 4 studies evaluated fetuses with an estimated fetal weight less than the 10th percentile using the following different classifications. 1. An estimated fetal weight less than the 10th percentile. 2. Abnormal growth defined as growth restriction or small for gestational age using the Delphi consensus. 3. The type of the estimated fetal weight growth deceleration. 4. The deceleration rate of the abdominal circumference. Irrespective of the definition used to define abnormal growth, there was a significant increase in fetal growth following 2 weeks of maternal rest.
That's perfect. Please go ahead.
Oh, excellent. Okay, very good. Okay. Well, basically, let's start about getting on the same page about probably the most amazing things about the pregnant uterus, and that's the change in volume and the contractile activity throughout the course of labor. As you all know, during the 9 months of labor, the uterus changes from a volume of less than 5 ml to over 4,500 ml. And during this time, the uterus remains senescent and with minimal contractions. When it's not pregnant, if you put a small volume in the uterus, it immediately starts contracting. So there's something different about a pregnant uterus that's really important. And this data I'm going to present today might help explain some of that. Then all of a sudden, during labor, regular firm contractions start, and over 12 to 24 hours, the uterine volume decreases, not quite back to its pre-pregnancy volume, but rather close. And why this is has really not been understood, and it's been research has been done on this for decades. And then probably something that people don't think about very much is that when the uterus is completely empty, at no matter what gestation, a contraction or contracture, which is a prolonged contraction, occurs. And this is, it doesn't matter how ready the uterus is, what contractile state it's in. And this, of course, is important for hemostasis and necessary for survival. So what the contemporary research for the last decades or so have been looked at the increasing contractility during the end of pregnancy. And certainly it does increase in contractility for multiple reasons. which I'm not really going to go into here, but it's a pro-inflammatory, prostaglandin and oxytocin driven. Not only does the contractility increase, but cervical ripening increases. And the theory now is somehow this just turns into labor, but why the other things I talked about haven't really been worked out. So what is the only parameter of the things we just mentioned that predicts labor? Well, all the obstetricians in the audience are well aware that is cervical softening or ripening, or what it results in effacement and dilation of the cervix. This is just a artist rendition of how the cervix effaces. So there's a thick cervix here, and then it's thinning up below. This predicts labor, and we'll talk more about the data for that later. So the question is, could labor result from an interaction between this certain increased contractile activity and cervical softening? And what would that interaction be? Well, according to the physiologic textbooks that you can read, there is a positive feedback loop between cervical dilation and contractions that increase contractility and result in labor. Other physiologic things that you might be familiar with that have a positive feedback loop include blood clotting, where there are things circulating in the blood that are inactive, and when bleeding occurs, these become a positive feedback loop and end in a clot. Urination is certainly another one where the bladder remains senescent and quiet as it fills, and then it reaches a certain point and the positive feedback loop results in urination. Well, the question is, could labor be a positive feedback loop involving the cervix and the uterus? And basically, the physiologic textbooks say it probably is. It looks like a prime example of that. And the question is, what's this based on? Well, it's actually based on the work of, it's not clear what it is, but what they base it on is the work of Ferguson, which was over 70 years ago, where cervical dilatation it has a neurologic connection to the pituitary, and the pituitary increases oxytocin release and causes contraction. This is still accepted as functional in many places, but there's several problems with it. The first one is no one in 70 years has been able to find a neurologic connection between the cervix and the pituitary. And the next one is that oxytocin, although rises slightly, doesn't rise enough to be what we believe is in the physiologic range to stimulate the uterus. And then finally, even if this was true, why would this continue in labor after the cervix is completely dilated? Clearly, at the end of the first stage of labor, contractions don't stop. So although this seemed like a great hypothesis, it doesn't really hold up. So could there be another connection? That's really the basis of what I'm presenting here. So the theory here is there is a positive feedback loop between myometrial shortening and prostaglandin F2 alpha connects that to contractile activity. As we know, that's a strong contractile agonist. And there's a positive feedback loop. Well, what is that loop? Well, it actually has two different parts. The first part is contractile cervical effacement and dilation, just as the Ferguson hypothesis held. But when the cervix is completely dilated, it's decreasing uterine volume. And both of these are connected to increased contractility through myometrial shortening. Now we're going to go into more details of this hypothesis, but let's first talk more about myometrial shortening, which is something people really haven't explored or hypothesized about before. During labor, contractile activity, of course, causes myometrial shortening as the uterus decreases in volume, but it's only when it's allowed by two familiar processes, which are the two we just talked about, cervical effacement and dilation and uterine emptying. Well, how do these result in myometrial shortening? Cervical dilation and effacement begins late in pregnancy, as we all know, before labor onset, and becomes more prominent during labor onset and continues till complete dilatation. How does it do this? It does this by the cervix replacing the myometrium in the uterine circumference. So as you can see here, the uterus circumference is made up completely of myometrium, except for the small part of the cervix here. But as effacement happens, the cervix thins and spreads out and takes up a good percentage of the myometrial circumference, which does not change as long as the fetus and the fluid stay in the uterus. You can estimate that this change, just with effacement alone, accounts for approximately 10% decrease in myometrial length compared to the term length. After, during and after, these are not independent events, they happen together often, but when cervical dilation starts occurring, which continues up to 10, I'm sorry, 10 centimeters, this again, as the cervix is pulled up, allows the myometrium to take up less of the circumference, and this dilation accounts for another 14% of myometrial shortening. Once dilation fully occurs, then the fetus can egress from the uterus, and fetal egressment from the uterus and delivery account for the rest of myometrial shortening, which is actually even more marked. It's even a little more easy to conceptualize this change, of course. As the volume decreases, then certainly the length of the myometrium decreases. If you measure the change in the myometrial circumference from full dilation but no egress to dilation to the perineal floor, the volume decreases approximately 24% compared to the total volume to start, the total length to start with. And then when the fetus is delivered along with the placenta and fluid, this accounts for another 32%, or a total of 80% shortening from the length of the myometrium before labor starts. Now, what stops this? Well, clearly, during most of labor, cervical resistance stops it, because a competent cervix prevents dilation and effacement, the cervical softening, and it also prevents fetal egress. If cervical competence is interrupted anytime during labor, during pregnancy, it results in fetal delivery. And except as you get closer to term, the fetus gets larger compared to the birth canal, and birth canal resistance takes over. This is why you can be completely effaced and even several centimeters dilated and not go into labor, because the myometrium still is not allowed to shorten by the birth canal resistance. So let's go through the hypothesis step by step now. During late pregnancy and before labor, this is what we hypothesize. The uterus is still senescent, contractile activity increases, and cervical effacement and dilation increases. However, as long as the cervical resistance remains greater than the contractile activity, there is no positive feedback loop. However, once the contractile activity at any gestation becomes great enough to continue to increase cervical effacement and dilation, this allows myometrial shortening, which increases prostaglandin production and increases contractile activity. This is the beginning of labor, and this is the positive feedback. That's the basis for this hypothesis. Once complete cervical dilation occurs, then this can no longer cause shortening. Shortening has reached its greatest point related to cervical effacement and dilation. So what takes over then is decreasing uterine volume as the fetus leaves the uterus. And again, these are not independent things. They all work together. They overlap, but it's a little easier, I think, to think of them one at a time. And this positive feedback loop continues throughout the remainder of labor. And then finally, once uterine, as you get to the end, you add to activity pushing, of course, and this allows fetal egress to the point of delivery. This is a rapid and the most dramatic decrease in uterine volume with dramatic myometrial shortening and uterine contracture, which again is necessary for hemostasis. And this happens at any gestation. All of us who've done a cesarean delivery at 24 weeks, the uterus is not ready, the contractile activity is minimal, it results in contracture. So let's now talk about the research that supports this. Probably the one that is newest to most people is that myometrial shortening changes and increases prostaglandin F2 activity. It's the only contractile substance that is made specifically by the myometrium. What we did is we took myometrial strips, and had been doing these contraction research for several years, and we noticed that as soon as the strips of human tissue were cut out, they contracted, and then when we put them in the bath, we increased their length at 2-gram tensions. This is a standard part of contractile experiments. It increases about 14% in length, and the contractions decrease. So our experimental design is once we got to the standard starting point for contractile experiments, we decreased the length by 14% to see if we could quantify an increase in contractile activity. And sure enough, we could. This is our data here from our publication in the American Journal of OBGYN. And what we found is that full length, the contractions were decreased. They didn't stop in most cases, but they decreased. And just decreasing the length by 4% after a period of time that was less than an hour, increased contractile activity, and this continued for almost 2 hours. So this increasing prostaglandins, we think, at this point, were temporary, but did decrease contractile activity. Now, what if you look at this same experiment, but you put indomethacin in? Indomethacin blocks COX-1 and 2, which are in necessary for prostaglandin production. And sure enough, the top one shows the shortened strips, and the bottom shows what happens when you add indomethacin. It actually decreases the contractile increase that we saw. So this, when you think about this, maybe this means that the increased contractions are due to prostaglandins, but it certainly could be we're just blocking two different things that increase contractile activity. Now, the thing that really surprised us about this series of experiments is that when we looked at the full length, the control strips, that we did not decrease in length with indomethacin. The full length strips are on the bottom here, the black ones, and the one within the indomethacin are the white squares. It actually increased the contractions in the strips that were relatively decreased from being on tension and then being at full length. So why could this be? Well, the obvious next step was to repeat the same experiments, but measure prostaglandins in the fluid when we did them to see, is it really what we think it is, or is there something else going on? We chose to measure two prostaglandins, the most potent myometrial contractile agonist that is actually made by prostaglandins. The only thing more potent than this is oxytocin, which is not made by the myometrium. And we also looked at prostaglandin I2, a uterine relaxant also made by the uterus. You can't measure this directly because it has such a short half-life. So we looked at PGF1 alpha in the fluid, which is a stable metabolite. And this is what we found. In the shortened strips, the controls had a basal amount of PGF2 alpha. And as you shorten them, it made more PGF2 alpha in a stepwise manner based on the amount of shortening. So this held up our hypothesis that shortening increased prostaglandin F2 alpha. The surprising thing, however, was the strips that were at 2 grams tension actually made a reasonably variable, but a certain amount of prostaglandin I2 metabolite. And when you shorten them, this decreased. So as it decreased, not only was the contractile agonist increased, but the relaxant prostaglandin was was increased, the relaxin prostaglandin was decreased. So looking at this in the standard fashion of how prostaglandins are made in myometrium and other tissue, it looks at like that the PGF synthase and the PGI2 synthase are differentially regulated by the tension of the uterus and the length of the myometrium. This obviously is preliminary research and certainly needs to be looked at in other models by other labs. So, well, let's for now go another step forward to look at some of the clinical evidence that supports this hypothesis. Now, there's actually probably 2 or 3 times this many if you think about it, and we published a paper earlier this year looking at all these possibilities. But for this short presentation, let's just go through 4 of these. The one that's just well known, has been well known a long time, is that cervical softness predicts labor. It's the only thing that we know that you can measure that does. Bishop first reported this 50 years ago. Cervical softening by the Bishop score could predict the success of induction of labor, and it could predict labor onset. In the more modern era, the same thing has been done with ultrasound, and it's much more quantifiable. This shows a fetal head by ultrasound and a long, thick cervix. And this shows the effacement has started, which it looks like a fetal funnel or cervical funneling here. And this predicts a labor onset, both preterm and term, and can actually be seen to be dynamically occurring during labor. This again goes with hypothesis that whenever the cervical resistance is low compared to the contractile activity, no matter when it is in pregnancy, this will result in a positive feedback loop that we described. Well, how about PGF2 alpha levels during labor? This is kind of interesting, and I don't have enough time to go deeply into this, but basically, PGF2 alpha levels do increase in blood and in amniotic fluid during labor, and they go down on the postpartum time. This, of course, fits what we're talking about. Well, where do these come from? Well, the fetal membranes make twice as much per milligram, but the placenta and fetal membranes together weigh, the myometrium weighs 20 times as much. So the majority of prostaglandins that are produced during pregnancy, right before it and during it, are made by the myometrium. Now, this is another really interesting fact about that. Although the levels are slightly increasing during labor onset, it's well established that the levels that can be measured in the blood are 700,000 times less than the ED50 for prostaglandin F2 alpha, and is much lower than the physiologic dose that we use to induce labor, that's used to cause contractions. So what this has led other researchers to believe, and we agree with, is that PGF2 alpha is unlikely to be initiating labor. It might be the result of labor initiation, and the effects of PGF2 alpha, if they affect labor, which we believe they do, are autocrine and paracrine made by the myometrial cells, not acting on the myometrial cells from other tissue. So another very interesting thing that is one of the things that really started me thinking about this hypothesis is that dystocia and contractile activity are related in a very unusual way. Now, for the people who are not obstetricians in the audience, dystocia is a failure to progress in labor, and it can be either caused by the contractile activity, the power, or it could be something to do with either the size or presentation of the fetus or the size of the birth canal. So let's look at this a little bit carefully about what we see is contractile activity often, not always, but often decreases regardless of the etiology of dystocia. Now, why would this be? How could this, if the contractile activity is the problem, of course, this is what you'd see. But if the fetus wasn't descending, or for whatever reason, why would this affect the activity? Well, it gets even more confusing than that when you use oxytocin to stimulate labor, which is the standard treatment for dystocia. then if the baby continues to descend, labor patterns stay well. But if there's arrested fetal descent, almost always, no matter how much oxytocin you give, you get a dysfunctional pattern of labor. How this doesn't fit with any known hypothesis prior to this one. Our hypothesis is if the fetus is not coming down because there's not enough contractions, or the fetus is not fitting, or there's the presentation is not ideal, then oxytocin, if it results in descent of the fetus, that makes more prostaglandin F2 alpha, and you have a good labor pattern. However, if it can't descend, the lower segment continues to stretch, and this allows shortening for a while, but eventually shortening becomes maximal without decreasing fetal volume, and the labor pattern decreases because there's not prostaglandin production continuing. So, and finally, when you empty the uterus completely, of course, the dramatic change in myometrial length results in a great deal of prostaglandin production, and this results in contracture regardless of timing. Now, people have brought up to me that obviously blood, which has the thrombin in blood causes uterine contraction, is a strong contractile agonist, but it's been well established that placental separation happens after contracture, and contracture is actually necessary for placental separation. So although this is obviously very important after the initial contracture to keep the uterus in a contractile state, it does not explain why you get uterine contracture at uterine emptying at any gestation. And one thing that people always it seems unusual, but most people wonder, is really the uterus just not a balloon? You know, when you empty it, it basically contracts back down. Well, it's not. It does not have any intrinsic elastic activity. What are the evidence for this? Well, the first one is postpartum uterine atony is common. So there is, if it was just an elastic issue, that would not be the problem. Second, if you look at a postmortem uterus, it is flaccid. It needs to be physiologically active to have contractile activity. And we, of course, in the laboratory see this all the time. Once the fetal tissue that we're working with, or the myometrial tissue we're working with, becomes flat, non-viable, it's flaccid. So, in according to the biomechanical hypothesis, prostaglandins are necessary for contractile activity, and the shortening of the uterus is what makes this happen. So the implications, again, this is could be a whole nother talk, but basically we've been kind of stuck in determining how to predict, prevent, and treat premature labor and uterine atony, two of the most significant causes of fetal and maternal morbidity, mortality, and having a new understanding of how labor starts and continues would allow us to hopefully develop many more methods for diagnosis and treatment. So thank you very much for allowing me to present this research, and we hope this continues on in our lab and other labs for years to come, and comes up with new ideas. Thank you. I guess there's probably not time for questions, but if there are, we can answer those.
At the Children's Hospital here in Victoria City, Tamaulipas, Mexico. The presentation of today is titled Maximum Velocity of the Middle Cerebral Artery and its Correlation with Anemia in Premature Newborns. Next, please. Okay, so as an introduction, there exist studies that utilize Doppler spectrum analysis to assess the middle cerebral artery blood flow velocity in fetuses for detecting some types of anemia, fetal anemia. These studies have demonstrated that the peak of systolic velocity of the MCA can correlate inversely with fetal hemoglobin levels. Specifically, they explain that it exists a strong correlation between the increase of the MCA peak systolic velocity and a decrease in fetal hemoglobin concentration that can be expressed as anemia. Next, please. So, with the previous background in this study, we were trying to prove the hypothesis that it exists a correlation between the measurement of the mean flow velocity of the middle cerebral artery and the blood levels of hematocrit in newborns, so we could obtain similar results to the ones that were obtained in utero studies. Next, please. For the methodology employed in this study, it was a prospective, cross-sectional, observational, and analytic study that was conducted in premature infants equal or less 34 weeks of gestation, and that were also admitted to our neonatal intensive care unit. And while they were admitted, we studied the relationship between the levels of hematocrit they had and the maximum velocity of the middle cerebral artery. Next, please. The measurement of the middle cerebral artery velocity was performed using a Doppler ultrasound, and the equipment we used was a Fujifilm sonocide ink model that employed a 2 to 5 megahertz convex transducer. For obtaining the images, we used the temporal window to identify the cerebral artery, and it was measured by color Doppler. Then the velocity was measured from 1 to 2 millimeters from the origin of the internal carotid artery, and we even zoomed the screen to more than 50% to obtain those images. Then the inclination angle was almost set to 0 degrees as possible without correction. After that, that we took our images, we obtained the blood levels of hematocrit by venipuncture that were processed at our clinical laboratory using a CELTAC ES MEK7300K hematology analyzer. During the whole stay of every patient, we took serial blood samples, and with the levels of hematocrit, we correlate them with the measurement of the maximum velocity of the MCA during the whole stay of every patient at our intensive care unit. Next, please. For our inclusion criteria, the patients that were accepted for this study were any kind of premature infants that did not have any degree of cerebral hemorrhage, any type of malformations of the central nervous system, that they were not intubated and had mechanical ventilation, and also that they did not have experienced any type of hypoxic ischemic event in the last 70 hours. We also excluded patients who had persistence of the ductus arteriosus, encephalopathy, any type of genetic disorder, or patients where we suspected an inborn error of metabolism at the time of the measurement. Next, please. With all the information that we obtained, we analyzed the whole data using an Excel database that then was transferred to the SPS 14 statistical software. For our quantitative variables, we use measures of central tendency, including the mean and standard deviation, as well as the t-test for population means. We also make correlations between continued quantitative variables using Pearson's correlation coefficient, and we use as a significance level of AP minus 0.05. And for our qualitative variables, we express them as absolute frequencies and percentages. Next, please. During our home study, we included a total of 32 premature newborns that were equal or less 34 weeks of gestation and that fulfill our selection criteria. From these 32 patients, we obtained a total of 98 hematocrit measurements, and from those 98 measurements, the mean of the levels of hematocrit were 35.13 plus minus 58.3 to 19.6 with a standard deviation of 8.72. From those 98 measurements, the mean of the maximum velocity of the ACM was 35.76 with plus minus 49 to 18 with a standard deviation of 8.45. And for our Pearson's correlation in the 98 hematocrit levels with the maximum velocity, we obtain an R minus 820, an R squared 0.673, an R squared 0.669, with a correlation of a P minus 0.01. For our regression, we obtain 4,668.7, a DF1, and a mean square of 4,668.7. Next, please. Next, please. Okay. Well, after that, in the previous slide, it didn't show, there was a table where we explained the correlationship between the levels of the hematocrit and the maximum velocity of the middle cerebral artery. In there, we showed that as a higher level of hematocrit, the lower the maximum velocity of the MCA we have. And as it descended the levels of hematocrit, our maximum velocity of the middle cerebral artery, it grew. Well, continuing with our presentation, after that, those 98 measurements of the hematocrit that we had, we divided them in two groups using the point of accord of 30% with hematocrit. We use this value because that means equal or lower hematocrit than 30% indicates any type of anemia. So with this division, in our first group, or the group number 1, we had a total of 66 measurements with an hematocrit measure of 30%. And from this group, the mean of the hematocrit was 39.38 with a standard deviation of 7.33. For our second group, we had a total of 32 measurements with hematocrit levels equal or less than 30%. And from this group, we obtained a mean of 26.3% with a standard deviation of 2.77. Also, for our first group, we measured the volume, the maximum velocity of the middle cerebral artery, obtaining for the first group a mean of 32.09 with a standard deviation of 7.66. And for our second group, the mean of the maximum velocity was 43.01 with a standard deviation of 3.65. After that, we compared the population means of both groups using a simple t-test, and for that analysis, we obtained a p-value of minus 0.05. That it means it was statistically significant. Next, please. Here is the table where it's basically what I just talked about, where we can see how we separate both groups using the levels of hematocrit, measure or equal or less than 30%, and the numbers of measurements that were included with their respective means and standard deviation. And as you can see, the P that we obtained of the analysis of both groups in both cases was significantly statistically significant with the p minus 0.05 with every measurement. Next, please. Next, please. So, the fetus with anemia can have many changes at the heart level, where the blood velocity increases due to a state of hyperdynamic activity. The viscosity of the fetal blood decreases, and that means it increases also the cardiac output. This is linked to a heart rate and stroke volume that it depends on greater cardiac contractility and decrease after the increased preload that is directly related to an increased venous return. So in this study, in our present study, the maximum velocity of the middle cerebral artery was measured because there exist studies that can correlate this parameter and the hematocrit level with a good correlation. And that means that at a lower degree of hematocrit, the maximum velocity of the middle cerebral artery increases, and conversely, at a higher level of the hematocrit, the maximum velocity decreases. Next, please. So this has a good predictive capacity in detecting fetal anemia because it's useful tool that we can employ with our patients. Also, fetal blood sampling during this procedure can have high risks such as miscarriage during the procedure. And they even exist some percentile values for the maximum velocity of the middle cerebral artery that can be employed in the studies. Next, please. So our results can agree with the published data on fetal Doppler and confirm that there exists an inverse correlation between the levels of hematocrit and the maximum velocity. But we should notice that we should make further investigations because our proportion of study was a little group, so we should make more studies about it and find a parameter where we should start doing a transfusion to our newborns, but that should be studied more in the future. Next, please. In a study by Weissman, he studied 150 neonates where he examined the peak systolic velocity of the middle cerebral artery. In this study, the measurement was taken during the first 36 hours of life in patients who were normosystemic, polysystemic, and anemic. And in the results, they showed that anemic neonates presented a significantly higher peak systolic velocity, and on the other hand, the polysystemic babies had a lower peak systolic velocity. So the author concludes that this technique can be used as an auxiliary measuring the degrees of anemia in babies. Next, please. Next, please. And finally, for our conclusions, we concluded that both fetal Doppler and Doppler in newborns is a very useful tool for measuring the maximum velocity of the middle cerebral artery and for detecting anemia of prematurity in correlates the increase in the maximum velocity of the middle cerebral artery with a low level of hematocrit. Thank you. Next. Thank you so much.
everyone, welcome to this talk about our Brazilian experience with the use of microfocused ultrasound in vulvar aesthetics, or intimate aesthetics as we also call it here. The use of microfocused ultrasound in the intimate area has become a valuable tool in Brazil for treating various aesthetic concerns in the intimate region. And here I will present our experience based on a study published in 2022, in which we shared our clinical practice and our experience with the use of this therapeutic resource for aesthetic dysfunctions in the intimate area. I am a physical therapist, graduated 32 years ago, and I have been working in rehabilitation and aesthetics for 30 years. I hold a master's degree in pedagogical sciences and have a postgraduate degree in acupuncture and pedagogical sciences, and I am the author of 2 books in the field of aesthetics. One specifically in the area of dermatofunctional physical therapy, which is the branch of physical therapy that deals with aesthetic dysfunctions, and another book focused on procedures in the field of Brazilian aesthetics. And the invitation to participate in this Congress came about because of this study we published in December 2022, where through a question from a student about whether there was treatment for intimate aesthetics, treatment of aesthetic dysfunctions in the intimate area, in the vulva area, in other words, on the external side of the intimate area with micro-focused ultrasound. And upon realizing that there was nothing, at least I couldn't find anything, I immediately gathered all the material I had, all the experience I had with the use of micro-focused ultrasound in intimate aesthetics, and included it in this study that we published in December 2022. And that's why the organizers of this Congress invited me to be here to give this lecture to you. The use of microfocused ultrasound in the intimate area is involved in various contexts, mainly emotional, psychological, and sociological. Look, there is no standard of female intimate aesthetics or beauty. There is no standard. However, many women, when faced with the image of vulvar aesthetics, of the external appearance of the intimate area, become involved with various emotional issues, several negative psychological responses, anxiety, insecurity, and depression. Brazilian women place a lot of value on the intimate area. They place a lot of value on this history, vulvar aesthetics. And look, in Brazil, there is a state, specifically Bahia, where in the city of Salvador, that is the capital of Bahia, it may be the place in Brazil with the highest number of clients seeking intimate area treatments, as well as a large number of professionals working in this field. There are groundbreaking works published by professionals who work and live in Salvador, Bahia. So we can say that in Brazil, the Bahia is the center or birthplace of Brazilian intimate aesthetics. So from there, many protocols, many treatments, many ideas, and many actions involving the use of resources for the intimate area spread throughout all of Brazil. So if you're thinking about going to Brazil to seek information on intimate aesthetics, Bahia, specifically Salvador, the capital, is the ideal place. The use of aesthetic procedures in the intimate area is already well documented in the literature, especially radiofrequency. Radiofrequency is one of the most widely used resources in the intimate area, especially traditional radiofrequency, like the one you're seeing in the video, where the treatment simply involves generating heat in the intimate region. And by heating the intimate area, there is a significant effect on the collagen and elastin in the skin. Radiofrequency in the intimate area is capable of promoting a series of beneficial effects. But in addition to radiofrequency, several other therapeutic resources are used in this region, including microfocused ultrasound. Microfocused ultrasound in the intimate area is already described in the literature by various authors for several conditions, such as vaginal atrophy, laxity of the intimate area, mainly the skin, and urinary incontinence, vaginoplasty, and a number of other conditions. However, in the external intimate area, that is in vulvar aesthetics, there are a few studies. When we wrote this paper, we hadn't found any other that discussed the use of microfocused ultrasound in vulvar aesthetics. However, today, we have already found some studies that talk about microfocused ultrasound in the external area, in the vulvar area, which is the main topic of our conversation here. Well, the RIFO system, the high intensity focused ultrasound, is a specific device. It's not new, it's actually quite old, with the first product introduced to the world in the early 2000s. Its main characteristic is the production of microcoagulative thermal lesions in the skin. So, microfocused ultrasound creates small thermal lesions with sound waves on the skin and beneath the skin. These thermal lesions progress to healing with collagen production, reduction of subcutaneous fat, and treatment of cellulite. There are various effects from the use of microfocused ultrasound in different conditions, including those involving the skin and subcutaneous tissue. And here's a video from a well-known company, the creator of the first microfocused ultrasound device, where they show the sequence of coagulation points. Here are the coagulation points made at 4.5 millimeters below the skin. Here at 3 millimeters, which already reaches the base of the dermis. And now at a depth of precisely 1.5 millimeters, which is in other words located right in the upper dermis layer of the skin. So microfocused ultrasound technology, through its specific action, is able to generate multiple thermal coagulation points at 4 distinct depths, 0.5 millimeters below the skin, and in the technique of microfocused ultrasound on the facial area, the use of microfocused ultrasound to reach this mass is extremely effective. So, this superficial aponeurotic membrane can be tightened by producing coagulation points, and at a depth of 4.5 millimeters, this is possible. 3 millimeters is basically used at the base of the dermis, and 1.5 millimeters is used in the upper dermis. In intimate aesthetics, we basically use two depths, 1.5 millimeters and 3 millimeters. So when we use microfocused ultrasound in the intimate area, we should prioritize the depths of 1.5 millimeters and 3 millimeters to focus only on the skin, to treat only the skin. Well, here's a bit about the physiology. Microfocused ultrasound is used at 4.5 millimeters, specifically in the area of the S mass. In the same session, right after, it is used at 3 millimeters, which reaches the base of the dermis. Sometimes it even reaches a bit of the subcutaneous tissue, but the main focus is the base of the dermis. And 1.5 millimeters is used on the upper dermis. So the upper dermis is targeted with the depth of 1.5 millimeters. And from there, these thermal lesions will trigger a cascade of therapeutic effects, mainly an inflammatory process and tissue repair, with fibroblasts being activated to produce collagen. And from that point on, from the day of the treatment up to 180 days later, significant changes can occur in the skin to the extent of minimizing a range of aesthetic concerns, such as sagging, wrinkles, elastosis, and various other aesthetic issues. So microfocused ultrasound basically works on the skin. However, today we already have several other devices that can reach a greater depth to treat subcutaneous tissue, but that's not the focus of our discussion here today, as we are going to talk mainly about microfocused ultrasound on the vulvar skin. And the main effect of microfocused ultrasound is collagen production. Now, before this work on vulvar aesthetics, we published another study in 2021. So in 2021, a year before the work on vulvar aesthetics with microfocused ultrasound, we published this study. In this study, we observed the main effect of microfocused ultrasound. Take a look here at these two cases that were treated in the research. We performed the microfocused ultrasound only in the left periorbital region, On the right side, we did nothing. Notice that here and here, there was a lift of the left eyebrow. On the left eyebrow, where the treatment was performed, there was a lift compared to the right eyebrow. And notice that in this volunteer, there was also an opening of the gaze. So the left periorbital region of both volunteers was treated, and the tissue, the skin from this region was removed and taken for histochemical analysis and compared with the skin from the untreated side. So here, the skin from the untreated side. Notice that on the untreated side, there was a predominance of type 3 collagen, which is the inferior collagen. Type 1 collagen was present in smaller amounts. But notice on the treated side that type 1 collagen appeared in much greater quantity than type 3 collagen. And this was observed 45 days after the treatment. So 45 days after the treatment, there was already a much greater amount of type 1 collagen than in the control group, 82% type 1 collagen and 18% type 2 collagen of type 3 collagen, making it very clear that the main effect of microfocused ultrasound is the production of collagen and good quality collagen, high quality collagen and type 1 collagen. And what about the immediate effect? Is there an immediate effect with microfocused ultrasound? Does the client already leave the clinic with treated skin? With skin that looks better? Look, this work here, this video shows the plasma jet, which in Brazil is popularly called the plasma jet, where the electric arc produces a beam of plasma on the skin, generating heat and causing contraction. Collagen can contract immediately. This is a thermal action. It's an effect of heat. And this video shows exactly what microfocused ultrasound can do to the skin. Microfocused ultrasound will also generate points of thermal coagulation in the skin, which can produce this effect you're seeing here in the video, the immediate skin contraction effect. Look, this is one of our results using microfocused ultrasound. Notice, the client arrived like this, as shown in the top photo, and left with her skin looking like this, making it very clear that microfocused ultrasound can contract the skin instantly, immediately. Here is the photo from the other profile. She arrived at the clinic like this and left with her skin much tighter. So microfocused ultrasound causes an immediate effect. I'm mentioning this because I'm going to talk about the results in the intimate area. Here is another client. You can notice a reduction in these wrinkles here. And on the left side, a much greater effect. The little wrinkles here almost disappeared in the bottom photo. In other words, an immediate effect from the microfocused ultrasound. Here you get a clearer idea. The wrinkle here was deeper. Here it became more superficial. Here deeper again, and here more superficial. Immediate effect of the microfocused ultrasound. And then the question is, do these effects last? When I show the results of intimate aesthetics, you'll see that they do last. Here is one of my students who, during a course, showed that she had an asymmetry in her eyebrows. Notice that her left eyebrow was higher than the right one. And we did the microfocused ultrasound only on the right side of her forehead, only here. And look, we evened out, we leveled her eyebrow. She came like this to a course. We did the microfocused ultrasound on the right side of her forehead and we evened it out. This was immediately after the treatment. So making it very clear that microfocused ultrasound can produce immediate results on your client's skin. Here, another work that also serves as a basis for this presentation and our study, which was published in 2016, where microfocused ultrasound was used together with intradermal therapy and a biostimulator. In this study, treatment with botulinum toxin and fillers was performed on the same day. So in general, you can use in the same day, in the same session, microfocused ultrasound, botulinum toxin, fillers, biostimulator, intradermal therapy, all of that in the same session. And what are the goals of vulva intimate aesthetics treatment, of female intimate aesthetics? Localized fat, which we won't address here, but it's very common. The treatment of fat in the mons venus. Skin laxity, wrinkles, which we will show a lot, asymmetries, which end up being influenced by this skin laxity and wrinkles, and hyperpigmentation, which we also won't address here. In Brazil, all of this is treated. In Brazil, all these conditions are widely explored, highly sought after by clients, and very well treated by Brazilian aesthetic professionals. We Brazilians do all of this here. But in our work, we emphasized only the treatment of vulvar skin, and that's what I'm going to address here. Well, this is a study published in 2020 where they combined filler and botulinum toxin with microfocused ultrasound in the same session. So notice here at the yellow arrow, the fold in the supraorbital region of this client's eye disappeared, as well as in this other one here too. The little fold gets smaller, okay? This is also a study done in Brazil carried out by a friend of mine, where in the first week he did the radio frequency. Here he used 4.5 millimeters and 3 millimeters with the hashtag technique, which I'll talk about in a moment. And he used a gluteal biostimulator. Look how interesting, even though it was a facial treatment, he used, together with the micro-focused ultrasound, a gluteal biostimulator. Because the substances contained in this biostimulator for gluteal skin also worked for the skin of the face. In the second week, he performed a micro-focused ultrasound again, but this time more superficially at a depth of 1.5 millimeters using the hashtag technique. And in the fifth week, he applied only the gluteal biostimulator again. And this client, she used a supplement based on hydrolyzed collagen with Verisol to boost collagen production. Well, you can see that there was a significant improvement over these 5 weeks of treatment, before and after, and here before and after. Notice the smoothing of this client's skin. Look, a lot of wrinkles here, and here a considerable reduction. Look, before and after, a really nice response. A very good result from the use of micro-focused ultrasound with a biostimulator. And this was a gluteal biostimulator being used on the face, something that we Brazilians do a lot. We call it alchemy, off-label work. We do this a lot. Sometimes we have some complications, some side effects, but most of the time, the results are very good. Here is a study published in 2021 where micro-focused ultrasound was used with calcium hydroxyapatite. Before and after, micro-focused ultrasound with calcium hydroxyapatite. In other words, 6 months later, look at the smoothing of the client's arm. On the other arm, the result wasn't as striking, but it did improve. And here is a study published in 2017, also on cellulite treatment, but this time using micro-focused ultrasound, also with calcium hydroxyapatite. Look, with the gluteal region relaxed before and after a single session, and here with the gluteus contracted before and after. In both situations, with the gluteus relaxed and contracted, the combination of micro-focused ultrasound and calcium hydroxyapatite produced very good results. And here, this is also a study conducted in Brazil, where micro-focused traction was combined with the use of focused electromagnetic field. Here, micro-focused traction was used to tone the skin between the muscles. So here, what highlighted the muscles was the electrostimulation with an electromagnetic field. However, the skin between the muscles was toned. It was treated with micro-focused ultrasound. This was also carried out by a friend, and I also followed the progress and development of this treatment. We ended up doing several sessions of electromagnetic field. In fact, there was only one session of micro-focused ultrasound, but there were 10 sessions of electromagnetic field. Well, now I'm going to talk about our experience, about what we did using micro-focused ultrasound in vulvar aesthetics. It's from the study I've already mentioned, but let me talk about a few more details regarding this work. As I mentioned, this work was published in December 2022. And it came about because of a question from a colleague, which led me to seek information about micro-focused ultrasound and intimate aesthetics. In this case, I gathered all the material I had on intimate aesthetics with micro-focused ultrasound and turned it into a scientific article. Why? I went to Salvador in Bahia 3 times to give a micro-focused ultrasound course for various professionals. And this course produced several results during the practical procedure. However, after the course, the professional students who took the course went back to their clinics, their workplaces, and started offering intimate aesthetics treatments using the protocols we taught in the classroom. And this led to a series of effects, a series of results, which characterized the working style of the Bahian professionals, naturally guided by the training I provided there 3 times in Salvador. So I gathered all this material and turned it into a scientific article portraying the Brazilian clinical experience with micro-focused ultrasound in vulvar aesthetics. And here are the results. Look, this is an immediate result. Immediate using the vertical vectorization technique, which is the hashtag technique. So there is a study that mentions the use of micro-focused ultrasound with the vertical vectorization technique, which is when you create coagulation points both vertically and horizontally at the same time. Take a look at this illustration. Look, here is a model of the vulva area where first the transducer is positioned like this and the coagulation points are produced horizontally. Then it is immediately turned and the coagulation points are made vertically. This causes the number of points in the area, the thermal coagulation points, to be greater, often resulting in immediate contraction or tissue repair. More pronounced, producing more collagen and generating a better effect. When we realized that this could be done, it was in the literature and started using it in the intimate area, the results were much better. So the results in the intimate area with the hashtag technique or vertical vectorization are much greater, much better. So look, today, here in Brazil, it's rare for us to perform micro-focused ultrasound without using the vertical vectorization technique, the hashtag technique. This here is an immediate result of sagging skin. Notice that there was a fold here, there was a whole irregularity. Look here as well. And before I finished putting together this presentation, when I saw this slide, I went to look for the photo of this client we had. It's been about 2 weeks, and she was seeking improvement. She underwent fractional CO2 laser treatment. And I took the before photo before the fractional CO2 laser. And look, her genital area looks exactly like this. It must have been about 3 or 4 years. 3 or 4 years, and that irregularity no longer exists. It still looks like this. And of course, there are still some little wrinkles here showing up. And now she sought treatment with fractional CO2 laser. Here, an immediate result. Notice the smoothing of the vulvar area. Look how irregular it was and look at how it turned out. This was immediate with a depth of 1.5 and 3, as I mentioned before. And here, 40 days later, look, the result was practically maintained. 40 days later, look at this result. Look how fantastic it is. Her genital area was quite deformed with a lot of sagging, very intense sagging. And look, 40 days after a single session at a depth of 1.5 and 3. So let me say something important. The vulvar tissue responds very well to heat and thermal injury. Today in our clinical practice, we are frequently using fractional CO2 laser in the intimate area with fantastic results as well. So the vulvar tissue reacts very well to heat. It reacts very well to heat, whether it's the heat from radiofrequency, pure and simple, or the heat, for example, from microfocused ultrasound, or fractional CO2 laser. If you heat the vulvar tissue, it will respond very well, just like you can see here in this image. Here we use the type of micro-focused ultrasound device that we call hands-free. Here are those pens that are used in motion in order to distribute several points of thermal coagulation. And that was the case here. Here is the before, and here is the immediate result. Only on the right side. You can see that it already changed on the right side, and here is the immediate result on the left side. It was like this, and look how it turned out. And here, 20 days later, let me show you the before and 20 days after. Before and 20 days later, the client's right side looked better, and the left side also improved, but not as much as the right side after 20 days. Look at this fantastic result 10 days later. This client's genital area was quite deformed. And look at the harmonious appearance. We also call this intimate harmonization. Look at the appearance. The skin was really deformed before, and here is how it turned out. A very good result in just 10 days, done in Salvador. Here we performed micro-focused ultrasound and immediately applied a biostimulator from a Brazilian company. A biostimulator manufactured and sold in Brazil. So micro-focused ultrasound. And here, just a detail about the technique. We performed the technique using plastic wrap, a PVC film, to prevent one client from transmitting anything to another. After each client, we remove the plastic, clean the transducer with 70% alcohol, and it's ready for the next client. So here, before and immediately after using the micro-focused ultrasound. It has already changed completely. We applied the biostimulator. So notice that before she was, let's say, empty. And now she is filled with the biostimulator. This is an immediate result, immediate, and it significantly changed her skin in the immediate result, as it's already clear that microfocused ultrasound does. Here, 45 days later, you can see a significant smoothing of the skin. And here, 90 days later, look at the quality of this client's skin with the use of microfocused ultrasound and the biostimulator. Well, to wrap up this lecture, I would like to make the following clear. The vulvar area is very receptive to thermal stimulation. That's a fact. Not only because of our work, but also due to all the literature reviews we've done, as well as the other resources we use in Brazil, and the global literature supports this as well. So if the focus is to treat the vulvar area, all you need to do is heat the vulvar area and you will get a strong and very good response. If the focus is to treat the vulvar area, you have a resource and an effective technique, and I'm sure you'll get a very good result. The vulvar area responds very well. And the complications and adverse effects are minimal if you know how to use the resource you're seeking. So look, the use of resources in the vulvar area aimed at normalization or aesthetic harmonization is extremely effective. It is widely used in Brazil and around the world, and it's worth investing in this procedure. It's worth investing in this technique. I can't speak for other countries regarding interest in the intimate area, but here in Brazil, a large part of the female population is seeking and valuing aesthetic treatments for the intimate area. From laser hair removal procedures to whitening treatments that specifically involve the delicate vulvar area, as well as the skin around the anus, but especially including various treatments for sagging and the appearance of wrinkles in this sensitive area. Well, and to wrap things up, let's take a moment to reflect a bit of God's word for our lives, because without God, I believe we are nothing and won't get anywhere. Even where there is gold and rubies in abundance, if there are lips that share knowledge, that will be even more precious. I thank you for the invitation to this Congress, because it is at this Congress that we will have many lips sharing knowledge, and I hope all the participants value this, because it is more precious than gold and rubies. May you all be blessed in the name of Jesus. Thank you very much for your attention, and see you next time.
Hello, my name is Dr. Karen Perry, and I'm going to talk about a case where I treated a patient for dense breast tissue using a therapy called FSM, which is frequency-specific microcurrent. All right, so here is my overview for the presentation. The first thing I'll do is talk a little bit about what is dense breast tissue, and then why did I choose to treat this patient for dense breast tissue in the way that I did. I'll talk about the treatment and the outcomes. And then this case report was published in November of 2023 in the Journal of Women's Health Issues and Care. So dense breast tissue. Here are some facts about that. Research suggests that dense breast tissue is a contributing factor to breast cancer risk. Increased density of breast tissue is correlated with higher rates of breast cancer, and women who develop breast cancer had a higher proportion of microcalcifications and dense breasts than women who did not develop breast cancer. And research suggests that reducing breast tissue density may help reduce breast cancer risk. So part of what I was thinking about as I was learning about this was, what actually is the cause of breast tissue? Is it microcalcifications? Is it other things? So there's a classification model out there that rates breast tissue in 4 different levels, from fatty to scattered dense tissue to dense, and then extremely dense. So it's a category A through D that are used. Here is a picture. So starting on the left-hand side of the page, that would be a fatty breast tissue picture. And then scrolling along, we have B with scattered areas of density, and then C is heterogeneously dense, and then D is extremely dense. So most women who get mammograms fall into the B and C category with just a little bit on the outsides. And I think it is true that younger women tend to start out in the A category. So, are there any current treatments to reduce breast density that can actually be applied to a breast? No, there are none as far as I know. So what I decided to do was to treat this patient with my frequency-specific microcurrent therapy machines, which is a therapy that I regularly use in my practice. Now, I am a chiropractor, and the majority of the problems that I see with people are a lot of musculoskeletal conditions. I treat a lot of scar tissue. I treat a lot of hard, fibrotic, ropey muscle tissue, and I use this FSM tool quite a lot to clear out calcium deposits, what are called oxalate deposits, scar tissue. I can also use it to remove toxin residues and take inflammation out of tissues, quite a lot of different things. So a little bit more about FSM. So FSM works on the premise that, yes, the body is composed of solid matter, but there's an energetic vibration specific to each part of the body that underlies that manifestation of solid matter. All right. And then additionally, each condition that affects the body also has an underlying energy frequency. The frequencies of the tissues as well as the conditions are expressed in hertz. For example, breast tissue, the breast ducts they correspond to the frequency 500. And so when thinking about this, I think it's useful to consider Newtonian versus quantum physics. Okay, quantum physics is all about the energy and the unseen. So with frequency-specific microcurrent, the condition frequencies that correspond to different conditions like inflammation or microcalcifications or something being torn are thought to use biological resonance to neutralize the effects of a specific condition in a target tissue. And then frequencies on the other channel that are targeting the tissues are thought of as resonating with the electromagnetic structure of the target tissue to change cell signaling and thereby change cell function and perhaps structure. So we talk about the conditions being the channel A frequencies and the tissues being the channel B frequencies. So here is the patient history. This was a 54-year-old woman. She's already a patient. I had already treated her for many things, including knee pain, neck pain, those kinds of things. She had a lot of achy, painful muscle tissue, and I found frequencies that worked with that, so I wondered if that would work in the breast as well. So let's see, in 2021, she'd had a mammogram, and with the actual compression of the breast tissue, she had 10 out of 10 pain in each breast. Her previous mammogram in 2018 was a 5 out of 6, 5 to 6 out of 10 pain. So it had gotten worse over a couple years. Now, I had previously treated her for oxalate issues in her joints and soft tissues. So I wondered if this particular condition is affecting one part of her body, maybe it's affecting the breast too, especially because oxalates are known to cause pain. They are sharp, sharp crystals that cause pain when compressed. She had complained of painful lumpiness in her breast tissue. Now, additionally with her history, she'd had mastitis in her left lateral breast 20 plus years ago, and a compression injury to that same spot. And in 2018 and 2021, she was diagnosed with dense breast tissue and a category C. So again, I thought to myself, why are these breasts dense and why are they so painful? So my first thought again was, well, maybe it's oxalate crystals. Oxalate crystals cause pain. The number that we use to correspond to oxalate crystals is 217. We also have a number for calcifications, which is calcium crystals without the oxalate component, and that number is 91. I wondered if scar tissue at 13 would be useful. Inflammation is 40. And then I wondered about estrogens and toxins, because we know there's a link between estrogen exposure and breast cancer risk. Here is a slide showing a very much blown up picture of oxalate crystals. They are sharp and painful. Oxalic acid from plants can combine with calcium in the body to form oxalate crystals. Mold and yeast can also produce oxalate crystals in the body. So if somebody has a yeast overgrowth problem or some kind of a fungal infection, those organisms can actually produce oxalate crystals as well. I treated this patient 7 times. The first, 7 times between November of 21 and April of 2023. The initial 4 treatments took place between 11 of 21 and March of 22. After each of the treatments, there was a marked decrease in palpatory tenderness and lumpiness. But over the next 6 months, some tenderness and lumpiness returned. So then we did 3 more treatments between September of 2022 and April of 2023, right before her next mammogram. I went through several different frequency pairs targeting conditions and tissues, but the ones that were the most useful were 91 for calcium deposits and 217 for oxalate crystals. Over those 7 treatments, it was only about 3 hours total time of treatment. Here is what the treatment setup looks like. So she's laying on her back, and you can see those leads. The leads come out of a little machine, and the towels are wet. So there's electricity coming down those black wires, but it's only about 100 microamps. It's a very small amount of electricity that isn't really felt by any of the patients. But the electricity comes out in the different pulsations for the frequencies. So that's how we apply the frequencies to the tissue. When there is a wet towel on one side of the body and another wet towel on the other side of the body, the current goes back and forth between those 2 towels, and that way it's able to penetrate that tissue. And in this case, it's able to penetrate the breast tissue. Most frequencies were applied for just 1 to 2 minutes. And during that time, the patient and I together would just very gently palpate the breast tissue in circular motions to help break up those calcium deposits and free them up from the tissue. So again, here were my best frequencies that I used. On channel A for the conditions, it was oxalates, calcifications, and then also infection for the left breast. There was still an energy signature of that old infection in there causing some pain and hardness. On channel B, I used mammary gland, capillaries, arteries, fascia, connective tissue, nerve, and fat. Subsequent to this, I started using 21 as well, which is duct for the actual ducts at the front of the breast tissue. So here's the outcome. We had good results. That mammogram was on April 25th, 2023. She had 0 pain in the right breast and a 4 out of 10 in the left breast. And it was the same amount of compression as her previous mammograms. And her 2023 new report rated her a category B with only scattered areas of fibroglandular density, not category C. And additionally, the radiologist put in a note saying the mammogram shows the breast tissue is not dense. Now this correlated perfectly with the patient's subjective findings that the bilateral breasts were much less painful and much softer than before the treatments. So here's an outcome chart where I put the 3 mammograms together. 2018 and 2021, she had, significant pain and then a lot of pain, and category C for both times. And then in 2023, it was a 0 out of 10 on the right, 4 out of 10 on the left, and rated a category B. So still a little bit of density, but not nearly as much. And again, here's that picture. So she went from a category C, heterogeneously dense, to a category B, scattered areas of density. So in conclusion, what I drew from this is that the FSM frequencies thought to reduce calcification and oxalate crystals in breast tissue may be useful in reducing breast tissue density, because that's what we ran and that's what happened. And then also the response is suggesting that breast tissue density may be related to the presence of calcium and oxalate crystals in breast tissue. The fact that the pain levels went so far down after these treatments suggests to me that the pain is related to those oxalate crystals, and also inflammation that would occur along with oxalate crystals in tissue. Oxalate crystals are known to cause pain and inflammation in tissues in which they are present. And breast tissue density is correlated with a higher risk of breast cancer. And also there is some research demonstrating a link between oxalate concentration in breast tissue and the development of cancer. So we know oxalate crystals cause pain and inflammation. We know that breast tissue density is correlated with a higher risk of breast cancer, and we know that increased oxalate concentration is correlated with higher risk of cancer. So if we can get rid of these oxalate crystals, in theory, we could decrease the risk of breast cancer. Here are some questions that I asked myself. The first one I wanted to know is, we got rid of a lot of these oxalate crystals and calcifications in that first round of treatments. Why did they come back, and how do we keep them out of there? One thing I mentioned earlier is that this oxalic acid that turns into oxalate crystals occurs in food. It occurs in plants and grains. So this patient adopted a low oxalate diet in order to prevent this recurrence again. So let's see. And then additionally, the results in this case suggest that we ought to study this more. Use more FSM to treat painful dense breast tissue and calcification so that we can reduce density, make mammograms more comfortable, and also reduce breast cancer risk. Now, I wanted to share one quick story about a different patient. This was a patient who had had several mammograms with dense breast tissue, and she had had suspicious biopsies before. And in her left lateral breast, she had a suspicious biopsy that turned out to be normal. We did this treatment on her, pretty much the same treatment, and then she went in, and actually what happened is that they actually found a very small cancerous nodule in that left breast. And what I believe has happened is that we cleared out some of those oxalates, so the imaging from the mammogram could get a better look at what was going on in there, and find very small bits of cancer before they got big. So she went through all the treatment for that. And with that mammogram that she had just done, her breast tissue did still come back as dense. So we were somewhat disappointed in that. But then she underwent her treatment and everything. And what's interesting is that her subsequent mammogram, I think she had it about 6 months later, her subsequent mammogram showed her having a category B down from a category C. So it seems like she had kind of a delayed reaction of decreasing breast density. So I thought that was very interesting as well. Very interesting. Here is a list of references that I used for this paper. Here is a link to the published article in the journal. And then lastly, here is a link to the FSM website that people can go to get a lot more information about frequency-specific microcurrent and other papers that have been written, and just really how it works, because it's a very versatile therapy. And then here is my contact information. So thank you very much for listening to my presentation. If you have any questions, feel free to reach out. I would love to hear from anyone. And thanks again.